Oh, everyone, good morning. Wishing you all a very happy Ganesh Chaturthi. I hope I'm audible and visible to all of you. If you are, kindly give me a confirmation that everything is fine so that we can begin our session. Okay, so I think the audio and visual relay is fine and we can go ahead and proceed with the class. So a quick confirmation from all of you will help me understand better if everything is fine. Okay, so till we have more learners joining in, quickly let me tell you what we have on offering from Unacademy. So of late we have come up with this very interesting batch which is called as the integrated batch and a system wise batch. So in this integrated batch which is starting from 25th of August, which we have already started, I have done an integrated session already with Dr. Ankit, where we have done ENT and anatomy integration together. So similarly, many subjects together will be integrated, which are of importance. It's not like randomly we are just integrating things, but there is a specific schedule of integrating things. So this integration is happening, and it is going to help you get perspectives from the subject from all the 360-degree point of view. So please do look out for this batch course, which is very interesting, which is integrated and system-wise batch course. So it is a full-fledged live batch on integrated concept coverage. It is offered only by Unacademy. August 25th, the course has started. It is a duration of 5 months. The first module is from August to October, where we're going to have dual educator series, not a single educator, but a dual educator series. MCQs and long form case discussion will be done, and in the class doubt solving by the top educators will be done. So the second module is a previous year discussion, which is from October to November for the same batch, and module 3 is image based discussion. So having taken the subscription, you are eligible for attending this batch as well as all the other batch courses that are coming up on Unacademy during the entire period of subscription. So you are entitled for listening for live classes, for recorded classes, and for everything. Now, we are also coming with QBank 2.0, so please keep updated about it. And if you want to subscribe for the batch courses, use the code ENT Live to get a 10% off. So the code is ENT Live. You can also attend the free classes, which are called as special classes on Unacademy, where we take special classes. All the educators take special classes in the month, and you will be able to access that for free. Even if you haven't taken a subscription, you will be able to access that for free. So with this, let's begin our class. A 40-year-old male comes to a ENT clinic for evaluation of hearing loss in his right ear. A tuning fork test is performed by placing the tuning fork on the vertex. The patient hears his hearing better in the affected ear. Examination is normal. And what is the underlying cause of this patient's hearing loss? Is it labyrinthitis? Is it Meniere's disease? Is it otosclerosis? Or is it noise exposure? So I'm waiting for the answers from your end. So tell me which is the right option. I'm waiting for all of your answers. So they're telling to you that the patient is coming to the ear with hearing loss in the right ear. And when you do a tuning fork test, you see that the sound is getting lateralized towards the affected ear. So where is the sound getting lateralized? Towards the affected ear. Ear examination is normal. What is the underlying cause of this patient's hearing loss? So if you see, whenever the patient is complaining to you of hearing loss, and when you keep a tuning fork in the midline and the sound is getting lateralized towards the affected ear, it means the patient is having conductive hearing loss. The test that we have done is Weber's test. So if on Weber's test, the sound is getting lateralized towards the same ear, deceased ear or the affected ear, it means the patient is having conductive hearing loss. Now, if there is a conductive hearing loss, there must be some pathology either in the external auditory canal, either in the tympanic membrane, or either in the middle ear, because conductive pathway is from the pinna up till the foot plate of stapes. So this entire pathway is your conductive pathway. So if your conductive pathway is having a problem, it will result in conductive hearing loss. But here they have told you the ear examination, the tympanic membrane examination is normal. So ear is normal, tympanic membrane is normal. Then where is the pathology? The pathology can be here in the foot plate of the stapes. And if there is fixation of the foot plate of stapes, we call that condition as otosclerosis. So otosclerosis is the condition where the patient can have conductive hearing loss, sound getting lateralized towards the same ear, tympanic membrane external auditory canal examination will be normal. Now in labyrinthitis, Meniere's disease and noise exposure, these are all examples of sensory neural hearing loss. So in sensory neural hearing loss, when you do a Weber's test, it is not lateralized towards the same ear, but it is lateralized towards the opposite ear. So is this clear? Even if you do the odd man out rule also for this particular MCQ, you will be able to rule out because 3 of them are sensory neural pathologies, whereas otosclerosis is the only conductive pathology. Very good, Aditya. That's the right answer. The second question goes like this. Structures seen on anterior rhinoscopy are all except internal nasal valve, middle turbinate, superior turbinate, inferior turbinate. Prashant, the question is structures seen on anterior rhinoscopy are all except. So what is not seen on anterior rhinoscopy? So you got to answer that. So do you see internal nasal valve? Do you see middle turbinate? Do you see superior turbinate? Do you see inferior turbinate? Do you see all these 4 structures, or there is some structure that you cannot see? Except means which is not seen. Okay, so let me show you the diagram that you see on anterior rhinoscopy. Let us label it. Okay, so one by one, the structure that has been pointed here, what is this? This is called as the columella. Okay, so this is the columella of the nose. Now, all of you can see here, there is a prominent projection here in the lateral wall of the nose, present inferiorly. What will be this? What will this be called as? This is your inferior turbinate. What is it? Inferior turbinate. You see another second projection here on the lateral wall of the nose. This is your middle turbinate. This structure on the medial side, the medial wall of the nasal cavity is formed by septum. So medially you have the septum. Okay. So medially there is septum. Laterally there is middle turbinate, there is inferior turbinate. Okay, so you can see this. Do you see superior turbinate which is located very superiorly and posteriorly? Obviously you cannot see. Now this structure between the septum medially, lower border of the upper lateral cartilage superiorly, and the head of the inferior turbinate inferiorly, this angle is called as internal nasal valve. So what is it called as? Internal nasal valve, which is the narrowest portion of the nasal cavity. So what is the importance of internal nasal valve? It is the narrowest portion of the nasal cavity. So internal nasal valve is bounded medially by the septum, superiorly by the lower border of upper lateral cartilage. This is also called as limen nasi, and inferiorly by the head of inferior turbinate. So can you see that also on anterior rhinoscopy? Yes, you can visualize internal nasal valve also on anterior rhinoscopy. So the structures seen are internal nasal valve, middle turbinate and inferior turbinate. Superior turbinate cannot be seen on anterior rhinoscopy. Clear? Everyone is understanding this? And the name of this speculum that is used for examination is called as Tudicum's nasal speculum. So this is called as Tudicum's nasal speculum. Okay. All are true about the following condition except can cause caloric reaction, direction of the jet is straight towards the tympanic membrane, contraindicated in perforation of the tympanic membrane, none of the above. So I'm waiting for answers from all of you. They are doing a procedure over here. All of the following are true about this particular condition except. So what is not true? So Akshay Purohit says 2. What about others? I'm waiting for the answers to come. So you can see they are doing something for removal of wax. They have kept a nozzle here and they are putting water and probably trying to clean away the wax that is there in the external auditory canal. So when you do this process, we call this process as syringing. So when you're doing syringing in the ear, should you use water of normal body temperature, that is 37 degrees centigrade, or should you use warm water or should you use cool water? What temperature should be used? You should use temperature that is optimal, which is 37 degrees centigrade corresponding to the body temperature. If you use warm water or cool water, it can cause caloric reaction. What is caloric reaction? If you use warm or cold water, there can be stimulation of the labyrinth, and labyrinthine stimulation can result in vertigo and nystagmus. So this statement that it can cause caloric reaction is true. Now, direction of the jet, should it be straight towards the tympanic membrane that you want to cause a tympanic membrane perforation? No. Yes. So here, this is the false statement as rightly told by all of you. Whenever there is a perforation and if you do a syringing, there is a very high likelihood that you may aggravate the disease because you are using water, and water is a field for growth of bacteria. And already if there is a perforation and there is a possibility of middle ear infection, then syringing will obviously aggravate the disease and cause an active discharge coming from the middle ear. So it is contraindicated. So this is also true. So these two statements are true. The only statement that is false is direction of the jet is towards the tympanic membrane is false. So all are true except option number 2. Yes, very good, Abhinay and uh, Aditya. Cows is the mnemonic. Whenever you do a caloric test, cold water will induce nystagmus towards the opposite side, whereas warm water will induce nystagmus towards the same side. Okay, let's go to the next question. The following are used to perform a posterior rhinoscopy. Sinclair Thompson posterior rhinoscopic mirror, tongue depressor, both, none. I'm waiting for your answers. Which of them are used for performing posterior rhinoscopy? Do you use a mirror? Do you use tongue depressor? Do you use both or do you use none? So Abhinay says 1. Prashant Verma says 3. Very good. Let me see others. What is your answers? Ida Baron says 1. Abhinay says 3. Okay, so let me explain that to you. So when we do a posterior rhinoscopy, what is the aim of examination? Do we want to see the structures in the posterior part of the nose and nasopharynx? Is that the aim of examination when we are looking and want to insert the mirror? Yes. So what do? You will take a posterior rhinoscopic mirror called as St. Clair Thompson posterior rhinoscopic mirror and keep it behind the uvula to see the structures of the posterior part of the nose and the nasopharynx. When you're putting this behind the uvula and when you're seeing from the outside, what is happening? Are you having a good amount of space to visualize the structures in the mirror? No, there is a compromised space. So what will you do? You will put a tongue depressor and depress the tongue. So once you have depressed the tongue now, have you created more space to visualize the structures in the mirror as compared to before? Yes. Now can you see the posterior end of inferior turbinate, posterior end of middle turbinate, the posterior end of septum, eustachian tubal opening, torus tubarius and fossa of Rosenmuller all into this mirror? Yes, we can see all these structures and we can visualize clearly in the mirror. So you will require a St. Clair Thompson posterior rhinoscopic mirror and you will also require a tongue depressor. So both of them are required for doing this posterior rhinoscopy. I hope it's clear to all of you. So the answer for this question is both. You require St. Clair Thompson posterior rhinoscopic mirror and tongue depressor. So let's go to the next question. The following are used to perform a indirect laryngoscopy. Indirect laryngoscopic mirror, tongue depressor, both none. I'm waiting for your answers. Yes, you can reply to me in the chat box. I'm listening to your answers. Okay, so I see the answer as 3 in by most of you. So that's not the right answer. Let me explain you the correct procedure. When you're doing an indirect laryngoscopic mirror examination, what is the aim? What do you want to visualize? You want to visualize the larynx, right? So when you want to visualize the larynx, you will take a mirror and you will keep it behind the uvula facing it downwards. Now, if the tongue is in neutral position or if you have put a tongue depressor and depress the tongue, will it give you a better visualization? Or when you tell the patient to retract the tongue forwards, pull the tongue forwards, will you get a better visualization? So when you pull the tongue forwards, what will happen? Have you created space for for you to visualize better into the mirror? Yes. So instead of using a tongue depressor, you will ask the patient to protrude the tongue forward and then you will hold it between the fingers. You will insert the mirror, and now you will be seeing from outside the structures in the mirror. So in the mirror, you can see the base of tongue, you can see the epiglottis, you can see the vocal cords, you can see the false cords, you can see the airy epiglottic fold. All these structures can be visualized. So here you just require mirror. You don't require a tongue depressor, because tongue depressor will actually block your view rather than make you visualize better. So the structures that you will see from above downwards. So the first structure that you will see in the mirror will be base of tongue. The second structure that you will see will be epiglottis. Now from the base of tongue to the epiglottis, there is fold called as the glossoepiglottic fold. Glosso means tongue. Epiglottis is epiglottis. So these folds are called as glossoepiglottic fold. The spaces between them are called as vallecula. So what are these spaces called as between the base of tongue and epiglottis? Vallecula. You can see the arytenoids, and from the epiglottis to the arytenoids you have the airy epiglottic fold. Then you have got the true vocal cords. Above that you have the false cords. You can also see the structures of the hypopharynx in the mirror. So you can see pyriform fossa, post-cricoid region, and posterior pharyngeal wall. So these are your pyriform fossa. This is your post-cricoid region, and this is your posterior pharyngeal wall. So all these structures are seen in indirect laryngoscopy. So I hope it is clear why we are not using a tongue depressor here, but in posterior rhinoscopy we use a tongue depressor. Okay, in an emergency, an access to the airway was performed with this procedure. Identify the procedure. Is this tracheostomy, cricothyrotomy, cricoidotomy, or is this laryngectomy? Yes, I'm waiting for all of you. Good luck. Solve the question and give me the answer in the chat. Life SJD says cricoidotomy. Edeveron says A. Prashant Verma says A. Anybody else would like to say the answer? Would like to change your answers? Aishwarya says B. Abhinay says B. Okay. So what is this cartilage that you see here, which is the largest cartilage of the larynx? This is your thyroid cartilage. Below the thyroid cartilage, the next cartilage that you see here is called as the cricoid cartilage. So between the thyroid cartilage and cricoid cartilage, there is a membrane. This membrane is called as cricothyroid membrane. So whenever there is an emergency and you have to get an access to the airway, you will make an entry to this cricothyroid membrane and insert a mini tracheostomy tube. So this procedure where you make an access to the cricothyroid membrane in an emergency is called as cricothyrotomy. So the procedure that you see here is cricothyrotomy. So I hope all of you got it, that the procedure shown here is cricothyrotomy. Okay, let's do the next question. A male is brought to the emergency department after being struck by a motor vehicle. In the emergency department, the patient is noted to have blood coming out of his nostrils. His jaw is to be rigid. Mouth cannot be opened for further examination. What is the most important anatomical landmark to identify to establish a secure airway? Anterior triangle of the neck, angle of Louis, laryngeal prominence, xiphoid process. Yes, I'm waiting for your answers. Life as JD says 3. What about others? Satya Chitra also says 3. Edvaron says 3. Okay. So when there is a patient who's brought to the emergency department and this patient has been struck by a motor vehicle, the patient is bleeding from the nose. Can you do a nasal intubation in this situation? Is nasal intubation possible when you want to put the endotracheal tube from the nose? No, it is not possible because the patient is bleeding. So nasal intubation, not possible. The patient's jaw is noted to be rigid, cannot open the mouth. So when the mouth is not opening, mouth opening is inadequate. Can we do oral intubation like we normally do? Orotracheal intubation, we cannot do. So now, is this a cannot intubate, cannot ventilate situation? Because you cannot intubate through the nose, you cannot intubate through the mouth. Now, it is an emergency. Tracheostomy will take certain time. So, what is the emergency procedure to be done now? The emergency procedure that you will do now is called as cricothyrotomy, where you will puncture the cricothyroid membrane and insert a small tracheostomy tube or a mini tracheostomy tube. Why are we choosing cricothyroid membrane? Because it is very easily accessible and you don't have any vital or important structures overlying it. You can easily penetrate the cricothyroid membrane. Whereas tracheostomy, there are different layers of your neck. There is strap muscles, there is isthmus of the thyroid gland, and to identify the trachea itself might be difficult and covered with very important structures like anterior jugulars, innominate artery, etc. So because of these reasons, in an emergency, if you have to do and you have to get an access immediately within seconds, a cricothyrotomy is preferred over tracheostomy. Now, what is the landmark? How will you identify cricothyroid membrane? So the first thing that you will do is identify the laryngeal prominence. What is the laryngeal prominence formed by? The laryngeal prominence is formed by a very important cartilage called as the thyroid cartilage. Now, once you have identified the laryngeal prominence, you will pull it up. Okay, you'll pull the thyroid cartilage up like how they have shown it in the image. And so that it is stabilized. The lower border of the thyroid cartilage, you will feel it. Just go below the lower border of the thyroid cartilage and give a stab incision. You are into the airway. Now, once you are into the airway, you will insert the mini tracheostomy tube, which is why you're going to choose to do a cricothyrotomy. Now, if I tell you angle of Louis, or if I tell you suprasternal notch, or if I say you anterior triangle of neck, is that giving you a specific landmark to reach the cricothyroid membrane? No. But if I tell you identify the laryngeal prominence, just go at the lower border of that prominence, will you be able to identify very easily? Yes, that is why laryngeal prominence is the most important landmark for cricothyrotomy. A low tracheostomy may be indicated in scleroma of the larynx, multiple papillomatosis of the larynx, bilateral vocal cord paralysis, carcinoma of the larynx. So low tracheostomy may be indicated in which of these following situations? Yes, I'm waiting for your answers. Okay. So let me answer to you, what is normal tracheostomy? What kind of tracheostomy do you do normally? Normal is your mid tracheostomy. So what is it called as? It is called as mid tracheostomy. So normally you will do a mid tracheostomy. What is mid tracheostomy? If you do between the second and the fourth tracheal ring, if you do a tracheostomy, you will call it as mid tracheostomy. Then what is high tracheostomy? If you do at the first ring, it is called as high tracheostomy. The indication for doing high tracheostomy is whenever there is a laryngeal carcinoma and you're planning to do a total laryngectomy. So when you're removing the larynx, what is happening to the trachea down? It is going to get disconnected from the larynx and you have to bring that out as a permanent tracheostomy, right? So obviously, why will you go jump from after the larynx to second ring to make a tracheostomy? You will just go below it and make the tracheostomy at the first ring, right? So laryngectomy combined, when laryngectomy is done, you will combine it with high tracheostomy, which is going to be permanent for the patient. So indication for high tracheostomy is laryngeal carcinoma, in whom you are going to do a total laryngectomy. What is low tracheostomy? Low tracheostomy is below the fourth ring. Now, why do we do below the fourth ring? Why are we going so much lower down in the neck? So when we do a low tracheostomy, the indication is recurrent respiratory papillomatosis. So what is the indication? Recurrent respiratory papillomatosis. So if there is a patient who is having papilloma of the larynx, what is this papilloma caused by? It is caused by human papilloma virus. Now, is there a possibility that when you are doing a tracheostomy, there is a possibility of distal seeding of the papilloma because of the maneuvering, because of the movement that we do on the trachea? Possibly, yes. So do you want to be very close to the lesion or you want to stay far away from the lesion when you're doing a tracheostomy? You want to stay as far as possible so that there is no distal seeding of the virus and the patient does not develop tracheal papillomas or bronchial papillomas. So far from it is better. So in multiple papillomatosis of the larynx, you will do a low tracheostomy. So this is your answer. For carcinoma larynx, you will do a high tracheostomy. I hope all of you got this. A 5-year-old boy having dinner suddenly becomes aphonic and is brought to the casualty for complaint of respiratory difficulty. What is the most appropriate management? Cricothyrotomy, tracheostomy, humidified oxygen, Heimlich's maneuver. Aishwarya, I didn't get your question. What to do in already operated neck? I didn't understand your meaning for low tracheostomy or high tracheostomy. What is the question? Could you elaborate a little bit? Then I'll be able to explain to you. Yes, very good, all of you. So when a patient is having dinner, especially a 5-year-old boy, the child is having dinner and suddenly the child becomes aphonic and is coming to the casualty with respiratory difficulty. What is the most appropriate management? So in this situation, you are thinking that there is probably the food has got aspirated into the airway. So if the food has got aspirated into the airway, how are you going to protect the airway now, or how are you trying to get the aspirated material out? So the first step is called as Heimlich's maneuver. So children who are 5 years and above, it is okay to do a Heimlich's maneuver where you will give compression on the xiphisternum. This will displace the foreign body because it is giving positive pressure from below. And along with that, you will give back slap. So when you do chest compression, xiphisternal compression plus back blows, the foreign body will get displaced and can expel out. This is for 5 years and above. But for children who are lesser than 5 years, because they do not have complete development of rib cartilages, the xiphoid sternum, and their entire, the pleural cavity is very soft and fragile, it's not advisable to give this chest, the compressions on the xiphy sternum. In these children, you will just hold the child on the palm of your hand in the prone position and just give back blows. So you can support your palm on your knees or your thighs and you can give back blows like this. So when you give back blows, the foreign body will get displaced and come out. So this is for lesser than 5 years of age. This maneuver is called as Hamlet's maneuver. Okay, so let's answer the next question. Absent laryngeal click may suspect supraglottic carcinoma, pyriform fossa tumor, glottic carcinoma, post-cricoid carcinoma. So Aishwarya says previously operated neck in thyroid surgery if thyroidectomy is done. Aishwarya, even in that situation, even if thyroidectomy is done, you can still go for mid-tracheostomy. There is no necessity that you should go for high or low tracheostomy. Although there may be a little bit of scarring and that may cause you difficulty in performing the procedure. But if you have to choose to do a tracheostomy in a patient who's already undergone a thyroid surgery, it is always preferable to go for mid. Because if you go for a high tracheostomy, there will be possibility of subglottic stenosis. And if you do low tracheostomy, there is a risk of trauma to vital structure like the apex of the lungs, the pleura. If there is, high riding arch of aorta, subclavian vessels, all these risks of injury to great vessels is possibility if you do a low one. And if you do a high tracheostomy, there is a possibility of subglottic stenosis. So although it might get little difficult in a previously operated neck or an irradiated neck, but still you will have to choose to do a mid tracheostomy. Yes, so I see Prashant Verma answering it as B, Edeveron answering it as A. What about others? Absent laryngeal click. What does it indicate? What should it suspect to you? So absent laryngeal click is called as Boca's sign. So what is absent laryngeal click called as? It is called as Boca's sign. All of you can try doing this. You can hold the larynx between your thumb and the index finger and try to move it between your fingers. You can glide it very easily and you will feel a little bit of grating sensation. That grating sensation is called as laryngeal crepitus or laryngeal click. This laryngeal crepitus or laryngeal click commonly occurs because of the movement of the cricoid cartilage against the vertebra. So you can see hypopharynx is usually a collapsed structure. Cricoid cartilage is the only complete cartilaginous ring in the entire airway. So it's the only complete cartilaginous ring in the entire airway. So 360 degrees you have a ring. But do you see epiglottis, the thyroid, the rest of them are incomplete, they're deficient posteriorly. So when you push it against the vertebra and try to move, you will get that grating sensation. But assume there is a carcinoma behind the cricoid cartilage, which we call it as a post-cricoid carcinoma. Or there is a retropharyngeal abscess, or there is a prevertebral abscess. Now can the cricoid cartilage glide freely over the vertebra? It cannot, and you will not get that crepitus. So when you do not get that crepitus, we call that sign as Boca's sign, which is absent laryngeal crick or crepitus, which is seen in post-cricoid carcinoma. So this Boca's sign is seen in post-cricoid carcinoma. It is also seen in retropharyngeal abscess or prevertebral abscess. So retropharyngeal or prevertebral abscess. Okay. So absent laryngeal click may suspect post-cricoid carcinoma. So I hope all of you got the answer to this question. Okay, so let's answer the next question. A mother brings her 6-year-old ill son to you. She claims that her voice has changed and he has fever. His sister and had flu. You notice that the child has dried up. Which of the following statements are true regarding the management of this patient? A thorough ENT examination is not required, including inspection of the throat. The child may be sent home and the mother given advice for paracetamol administration. Antibiotics are not needed as it's probably a viral infection. The child may be made to cry as it will cause vasoconstriction and relieve his neck swelling. So all the best, give me the answer. So Aishwarya, you are asking me in trauma. In trauma, the first way of securing the airway would be cricothyrotomy. Okay, so if you cannot intubate, cannot ventilate the patient, then you will do a cricothyrotomy. After that, you will convert it to a tracheostomy. Prashant, I'll show you there is a typical sign here. What is this sign called as? Yes. So in thumb sign is seen in which condition? Yes. So in acute epiglottitis, do you want to make the child cry as this will cause vasoconstriction and relieve the neck swelling? Is this statement true or false? Is this statement true? When the child will cry, there is a negative intrathoracic pressure. This negative intrathoracic pressure pulls the air inside the trachea. Now, is this going to further compress the laryngeal inlet because the epiglottis also will get sucked in or pulled in when the child cries? So, will this aggravate the stridor or will this relieve the stridor? So, is this statement true that should you make the child cry? No, this is false. So this is a false statement. Okay. Now, is this a bacterial infection or a viral infection? So do you want to give antibiotics or antibiotics are not needed? Come on, tell me quickly. So is this statement true or is this statement false? See, epiglottitis, yes, very good, JD. This is a false statement because epiglottitis is a bacterial infection. This is most commonly caused by Streptococcus pneumonia. So since Streptococcus pneumonia is the most common organism responsible for doing this, antibiotics are necessary. So antibiotics are not needed. This is a false condition because this is a bacterial infection caused by Streptococcus pneumonia. So this is false. Antibiotics are needed in the treatment. The child may be sent home and the mother given advice for paracetamol administration. This is false because it's a pediatric emergency. You can't send the child home with paracetamol. The child can go into respiratory distress and stridor at any point of time. So you have to monitor the patient. You have to give IV antibiotics. You have to give nebulization with racemic adrenaline and steroids. You have to give steroids, systemic steroids as well to relieve the airway edema, which cannot happen in house, which is why you have to advise the patient to stay admitted and not sent home by just giving paracetamol. Is a thorough ENT examination not necessary? This is a true statement because if you try to examine the throat and if the child goes suddenly into laryngospasm, there will be airway obstruction. So to prevent laryngospasm and airway obstruction, you will never examine, and a thorough examination of the throat is not required, including inspection of his throat. You will only send the child to X-ray. Once the X-ray is giving you evidence of thumb sign, you will just start the medication. You don't need to examine the patient, because if the child goes into laryngospasm, there may be respiratory obstruction and the child may collapse. So I hope all of you got the answer. Let's go to the next question. Which of the following formulas is used to calculate the appropriate internal diameter of a tracheostomy tube? Internal diameter is age in years by 3 plus 1.5, age in years by 3 plus 2.5, age in years by 3 plus 3.5, or age in years by 3 plus 4. What is the correct answer? So Rakesh Khimani says B. What about others? Is it 1.5 or 2.5 or 3.5 or 4? What is the correct answer? I'm waiting for all of you, at least a few of your answers, then I'll be able to discuss. Lakshman says C. Okay. So either of the formulas can be used to calculate the appropriate size of the tracheostomy tube. So when we want to calculate the internal diameter or inner diameter, we will always take age in years by 3 plus 3.5. So this is inner diameter. If you're taking the outer diameter, you will take, instead of 3.5, you will take 5.5. Okay. So this is the formula. This is the common question that you can expect. You can calculate on the basis of weight also. So outer diameter in millimeters, how will you calculate? Weight, say whatever the weight is, say 10 kgs into 0.1. So how much is 10 kgs into 0.1? That is equal to 1 plus 4.7, which is equal to 5.7. So you will take approximately a 6 size outer diameter of a tube. But if you're taking the inner diameter, you will take weight in kgs into 0.08. Instead of 0.1, you're going to take 0.08 plus you're adding to it 3.1. So instead of 4.7, you'll add 3.1. So on the basis of weight also you can choose a tracheostomy tube. But common question that they will ask you is on the basis of age. Age by 3 plus 3.5 for inner diameter. Age by 3 plus 5.5 for outer diameter. Okay, so this is a common repeat question which has occurred multiple times even in recent examination. So while doing the procedure in a patient, the patient coughed. It is mediated via which nerve? Auriculotemporal nerve, glossopharyngeal nerve, Arnold's nerve, or Jacobson's nerve? So I'm waiting for your answer. Very good. Aishwarya Chaturvedi says 3. Piyush also says C. What about others? Okay. So what is this procedure? They are trying to remove a foreign body. Excuse me. So when you're doing a foreign body removal, and when you're using a probe, foreign body hook or a foreign body probe to remove the foreign body, you are stimulating the floor of the external auditory canal. The floor of the external auditory canal is supplied by Arnold's nerve. What is Arnold's nerve? It is nothing but auricular branch of vagus nerve. So this auricular branch of vagus nerve will get stimulated whenever you do any probing of the external auditory canal, especially in the floor or the posterior wall. So posterior wall or the floor, you will have stimulation of this nerve. Now this vagus nerve also is responsible for causing cough reflex. So cough reflex is mediated whenever you are stimulating the Arnold's nerve. Arnold's nerve is also called as Alderman's nerve. So I think this is a very easy, quite a easy repeat question. Let us go to the next question. A 3-year-old child has been diagnosed as bilateral moderate sensory neural hearing loss. The best way for rehabilitation is hearing aid, cochlear implant, stapedectomy, brainstem implant. So I'm waiting again for your answers. So Prashant Verma says 4. Life SJD also says 4. Siddharth Chaturvedi says 2. So they're telling you there is a 3-year-old child. This child is having bilateral. Is it moderate hearing loss or is it severe hearing loss? It is moderate. What is the meaning of moderate? So 0 to 25. Just go on adding. Then I'll tell you how to label the hearing loss. So start with 0 to 25. Add 15 each time. So 26 to 40, 41 to 55, 56 to 70, 70 to 90, and more than 90. So every time you're adding 15, 15, 15, here you're adding 20. So 0 to 25 is normal threshold of hearing. So what is the normal threshold of hearing? 0 to 25. If it is between 26 to 40 decibel hearing loss, we call it as mild. 41 to 55, moderate. 56 to 70, moderately severe. 70 to 90, severe. And more than 90, profound. So is the patient having about 41 to 55 decibel hearing loss? So if a patient is having this much 51 to 41 to 55 decibel hearing loss, why is there a necessity for surgery? Why can a non-surgical method not help? It can help. So a hearing aid which will amplify the sound is given for a patient with moderate hearing loss. But if the same question would have been given to you for severe or profound hearing loss, then your answer would have been a cochlear implant. Okay. So if the patient is presenting to you with severe or severe profound hearing loss, then your answer is cochlear implant. Stapedectomy is done for otosclerosis. And brainstem implant is if there is a cochlear nerve pathology, not cochlear nerve pathology. If there's a retrocochlear pathology, then you will do a brainstem implant. So the correct answer is hearing aid. Okay, the next question. A child is normal while crying but develops cyanosis and breathlessness at rest. The most probable diagnosis is laryngomalacia, croup, choanal atresia, epiglottitis. So Rakesh Khemani says 1, Prashant Verma says 2. What about others? Any other answers to differ, or would you like to stick to these answers only? Okay. So they're telling to you that a child is normal while crying. Meaning when the child is crying, he is having no respiratory distress, but there is breathlessness at rest. Now let us see what happens in laryngomalacia. Laryngomalacia, there is excessive flaccidity of the epiglottis. So on crying, will the epiglottis get sucked in because of the negative intrathoracic pressure, and is it going to aggravate the disease or is it going to relieve the stridor? It will aggravate. So can this be the cause? No. In croup, there is inflammation of the entire airway, the larynx, the trachea, the bronchus. Crying will further increase the inflammation and narrow the airway. So on crying, will the child be normal? No. Choanal atresia. So if there is a bilateral choanal atresia, the child cannot breathe from the nose, cannot breathe from the mouth. So when the child cannot breathe from the nose, child cannot breathe from the mouth, because infants are obligate nasal breathers. They do not know mouth breathing until 3 months of age. So when the child cannot breathe from the nose, cannot breathe from the mouth, at rest the child will have respiratory distress and stridor. So at rest, there will be respiratory distress and stridor. But when the child cries, what is happening? The child is opening the mouth to cry, and there is a negative intrathoracic pressure that is pulling the air in. So on crying, will there be relief of stridor? So this is for choanal atresia. Epiglottitis, we've just understood that when there is inflammation of epiglottis, crying will further aggravate the stridor and not relieve the stridor. So in all these rest of the three conditions, crying will aggravate and the child will not be normal. But on crying, if there is relief of stridor, then it is choanal atresia. So I hope all of you got the answer. Okay. So let's go to the next question. A patient presents to the casualty following injury on his face. His CT is given below. The most probable diagnosis is Leafort 1 fracture, blowout fracture, tripod fracture, Chevalier fracture. Yes, very good. Most of you have answered this absolutely right. So this is a fracture of the floor of the orbit, and you can see the orbital fat herniating into the maxillary sinus. This sign is called as teardrop sign. This teardrop sign is very, very classical for blowout fracture of the orbit, which is nothing but fracture of the floor of orbit. So the sign that you see here is called as teardrop sign. So I think everyone answered this right. So let me take you to the next question. Mulberry appearance of the turbinate is seen in coryza, atrophic rhinitis, maxillary sinusitis, hypertrophic rhinitis. So Prashant Kumar says B, Ritesh Rakesh Khimani says 2, Life as JD says 4. I'm waiting for some more answers to come in. So what is mulberry appearance of the turbinate? When the turbinate becomes boggy and edematous, something like this, resembling the mulberry fruit, we call it as mulberry appearance of the turbinate. So will this be seen in atrophy or hypertrophy? Obviously, since it is bulging and boggy, it will be seen in hypertrophic rhinitis. It is a turbinate which is present in the nasal cavity. So can sinus disease called appearance, sinusitis cause appearance of turbinates? This can never be the answer. In atrophic rhinitis, there is small turbinate. There is not enlargement of turbinate. There are small turbinates. So this cannot be the answer. Coryza again will just lead to inflammation, but it will not result in any hypertrophic rhinitis. So hypertrophic rhinitis will result in mulberry appearance of the turbinates. So this is the correct answer. So with this, I will stop my class, and I hope you guys enjoyed this 1 hour session that I had taken starting from 9 a.m. till now. And we've covered quite a few general questions. They were not specifically related to otology or rhinology. The questions which are generally asked, like as a, which are in the gray zone, which may come, which may not come. I have tried and focused to get you all those questions over here. So I hope to see you all on Unacademy classes. There is something called as special class for those who do not want to subscribe and would like to listen to my classes there. It's for free. So you can come and log in for the special classes. Again, the login code for the free classes that you would want to listen is ENT Live. For those who would like to subscribe for the classes, again use the same code to get a 10% off. Please do look out for the integrated batch course that is coming up. That has already started from 25th. That is a dual educator series where you get perspectives from dual educators holistically covering the topic 360 degrees. And it's not going to be a theory course, it's an MCQ oriented course and a clinical case history examination oriented course. So it will definitely help all of you. So hope to see you all. Until then, take care and bye bye.